Hello and welcome to this second video from Lakewood Ranch CERT from our skills refresher session. In this one we will look at rescuer safety, we'll look at medical operations and look at triage and tourniquets.
Hey, good morning all from Nigel's Command Center. I think you will all agree that our CERT training is focused on disaster preparedness and disaster response. Now, when there's a disaster, whether it's a hurricane or tornado or a flood, there's always the potential for a mass casualty situation. Now, a mass casualty situation is one in which there are more victims than caregivers. Now, this is the last time we can use that term victims because FEMA has now changed that term to survivors. So a mass casualty situation is now survivors who need more care than there are caregivers. Triage is the tool that we use in this case to prioritize treatment. Now, triage is really directed at the three life-threatening conditions, that being airway obstruction, bleeding, and shock. Remember, we don't do CPR, we don't do artificial respiration because that confines one caregiver to one survivor. And we need to keep moving and do the greatest good for the greatest number of people. Treatment for less urgent conditions are delayed. Now, these are our yellows. The life-threatening conditions are our I's or our reds. The delayed conditions are our yellows or greens, and they're the delayed or the walking wounded. We have a new environment that we're working in. Before, we were using protective equipment, that being helmets, goggles, work gloves, sturdy shoes to protect ourselves. We also had exam gloves to prevent, contaminating fluids from touching us. Now in the COVID environment, we have another thing to consider, and that is aerosols. And so in each one of our team kits, we have added face shields and surgical masks to remedy this situation. Now keep in mind that your vest and your ID badge will identify you as a responder rather than a looter. It will also allow you to operate in the event there's a sheriff's curfew. The phases of death are as follows. In phase one, we have people who are going to die in the next few minutes because of severe trauma. This could be people that are not breathing or that have arterial bleeds where they're bleeding excessively. Phase two, and I don't know why we still say excessive bleeding here, but the death within hours is a result of bleeding and shock, but not necessarily arterial bleeding, and it can be death within minutes. Finally, we treat phases 1 and 2, and if we do our job properly, we prevent phase 3, which is death in weeks because of infection. Now, what is triage? Triage is really the process for evaluating survivors and sorting them by the urgency of treatment. Now, we're only going to be treating the immediates, and these are the people with the airways, bleeding, and shock. And then we're going to tag the others for delayed treatment. Now, this is called the START process, which is simple triage and rapid treatment. The killers, once again, airway obstruction, bleeding, and shock. The priority for treating these, obviously, is to open the airway and get them breathing first. Now, if you have a partner, or we will be working with a partner, and so if there are two situations where we have airway and bleeding, one takes care of the airway, the other addresses the bleeding. Shock is the final thing that we treat as far as the killers. Now, in approaching a victim, the thing that's important is that you identify yourself. Make sure that they know you're a responder in your organization, and it just doesn't have to be a full resume, but it's nothing more than identification. You need to ask permission to treat. If they are unconscious, you already have that advised consent. Now, respect cultural differences, obviously. If it is a wife-husband situation, then you ask one for the permission to treat the other. Parent-children, you're asking parents to treat the children. Protect their privacy, and the assumption now is that everyone is a COVID-19 infection. And so keep your personal protective equipment in place at all times. Airway obstruction is really in an unconscious patient in which the tongue muscle relaxes against the soft palate of the throat and it obstructs the airway. Now, in this situation, because they're unconscious, we have to consider the possibility of a cervical spinal injury. And so that's why when we originally taught this, we were using the head tilt chin lift method because it provides the minimum of spinal manipulation. It keeps an alignment of the head and the spine once the person is on their back. And of course, if they're not on their back, then we have to carefully turn them, supporting the head and maintaining that alignment of the head and spine. And now we are essentially putting a hand on the forehead, fingers under the jaw, and lifting and tilting the head backwards. Now, let's get a little bit of a simulation right here. There we are.
So thinking about basic airway maneuvers, the first one that we can do is a head tilt chin lift. And to do that, we're going to take one hand and place it just on top of the patient's forehead. Take our other hand and just put two fingers just underneath their mandible or their jaw. We're then just going to lift gently upwards with this other hand. And in doing so, that opens the patient's airway, removes the tongue off the back of the soft palate, and hopefully provides us with a patent airway initially. If you have a person you suspect
Now, as I say, this was the technique that we have been teaching because we thought it was the least invasive for any C-spine injury. Now, what FEMA is telling us to teach is the jaw thrust maneuver. This one gives you no manipulation of the head or the neck. All you're doing here is simply moving the jaw to open up the throat passage. Now, we have a sequence to show you how to do this, but the thing that I found is you can't really do this on a conscious patient because it kind of hurts. And so we have purchased a mannequin that it can be used for our first aid training, and also if we want to see it or use it for team kits, our team meeting exercises.
If you have a person you suspect has a head, neck, or spinal injury, you can open the airway using the jaw thrust maneuver. The jaw thrust maneuver allows you to open the airway without moving or tilting the head back. You lift the jaw up with your fingers along the jawbone. If you are not able to open the airway properly using the jaw thrust, use the head tilt chin lift maneuver to open the airway. It is more important to have an open airway for a non-breathing person than to care for the spinal injury. You would suspect a spinal injury when the victim complains of neck or back pain, tingling in the extremities, or weakness. The victim was injured, diving into shallow water. There is obvious head, neck, or back injury. The victim was an occupant, rider, or pedestrian in a motor vehicle, motorcycle, or bicycle crash, or the victim was injured from a fall greater than standing height. Some of the signs and symptoms include bruising of the head, especially around the eyes and behind the ears, blood or fluids in the ears and nose, seizures or changes in level of consciousness, impaired breathing, vision, or body movement, severe pain or pressure in the head, neck, or back. Now we will examine the jaw thrust maneuver in detail. First, firmly and securely place your hands alongside the victim's face. You want to be careful not to move the head or the neck in this situation. Your fingers will be placed at the bottom of the jawbone. Your thumbs will be placed firmly on the victim's cheekbones. To open the airway, you will press down with your thumbs on the cheekbones and lift up with your fingers on the bottom of the jawbone. Practice performing the jaw thrust maneuver. Remember, place your hands firmly alongside the victim's face. Your thumbs will be placed at the top of the cheekbones. Your fingers will be placed under the bottom of the jaw, and your fingers will lift up on the jaw while your thumbs press down. This will allow you to open the victim's airway without moving the head or neck.
This is the CAT Gen 7 combat application tourniquet. The CAT has been used by the U.S. military since 2005, and it has helped save countless lives.
We'll get to that in a minute. Now, once again, the jaw thrust maneuver results in less manipulation of the head and neck. However, if you remember from the video, it said if you don't open it, the airway with the jaw thrust maneuver, trying it a couple times, then we go to the head tilt chin lift method. Opening the airway again, we're approaching the survivor and calling out, "Can you hear me?" If they don't respond, assume unconscious. We're checking for breathing, first of all, then palm on the forehead, 2 fingers under the jaw, tilt the head, listen by mouth, and put a hand on the abdomen. Now, what are you going to hear when you have your adrenaline running and you're trying to do everything to try to help this survivor? So you're going to hear yourself breathing at a very rapid rate. So the hand on the abdomen is probably going to be the best indication. You're looking for the chest to rise, you're listening for hair exchange, and that abdominal movement is the real key. If that doesn't work the first time, increase the tilting of the head and repeat 2 through 7 once. If that does not cause a air exchange and to start breathing, then it's time to tag them and keep moving on. Again, we're doing the most good for the most people. If we get them breathing and there is someone there to monitor their condition, then we get them into the recovery position. And the recovery position is really moving them onto their side with the head tilted down to prevent any kind of choking on, any kind of regurgitation. Now, in moving them to their side, you and your partner have to work together, because this becomes a situation where you must maintain the spinal alignment of the head and the back so that we're not causing any problem. Again, the head is now going to rest on the hand, which is not shown here.
Pat,
excuse me.
we have a question about the jaw thrust.
Yes.
Do you need to keep your hands on the survivor's head in position while you're doing that maneuver?
You have to, because what happens is you are actually holding the jaw open until breathing starts. And so that's where it becomes a very uncomfortable thing to do with a conscious patient.
Thank you, Pat.
Instead of just doing one move, you've really got to hold it open to make sure that the throat passage is open. Now on to bleeding. If we start thinking about the average adult body has about 5 liters of blood. If we lose 1 liter, 20%, we can start inducing shock, and after that it cascades down further as more blood loss occurs. Now, the 3 types of bleeding, of course, are arterial, venous, and capillary. In the arteries are the vessels that are usually deeper in the body and carry blood under pressure away from the heart. And so an arterial bleed will spurt. Now, this is usually a puncture or a deep laceration or an amputation, but this is the most critical. you can bleed out in 5 minutes from an arterial bleed, and that causes death. The veins are more superficial vessels, and they do carry large volumes of blood, but they're under lower pressure. This is the vessel that carries the blood back to the heart. And so at the lower pressure, the blood loss will flow. Still looks like a great loss, but it's not spurting. And the capillaries are very fine vessels, and so any bleeding from the capillaries will simply ooze. Now, one thing that we'll talk about later is the use of tourniquets. And in the case that we have a full amputation or a partial amputation, we may not be presented with any bleeding. And that means the body has already gone into its own self-preservation mode in which the vessels contract and we stop the bleeding that way. However, that will not persist. And so we actually go to a tourniquet immediately to prevent excessive loss of blood in an amputation or a partial amputation. Now, the best method for controlling bleeding obviously is direct pressure. Now, this means we take a sterile dressing, and the dressing only remains sterile by the way you handle it. So a 4x4 comes out of the package, you hold one side, and the sterile side goes against the wound with direct pressure. If it's bleeding through, then more dressings on top of that. The important thing to remember is the only dressing that really has to be sterile is the one present on the wound. Other dressings don't need to be sterile, and you're probably going to go for them very quickly after you bleed through on the first. Direct pressure, and you're holding pressure right against that. Elevation is the second. In other words, with elevation, we're trying to get the wound above the heart because the heart doesn't pump well against gravity. And finally, the third way of controlling this is pressure points. Now, the pressure points are really methods that we use to restrict the arteries carrying blood to the particular wound. In the case of the arm, the brachial artery is coming down the arm, and so the brachial pressure point is just above the elbow. In the leg, the upper leg, the femoral artery, the femoral pressure point is in the upper part of the leg, and then finally the popliteal pressure point is behind the knee, and the popliteal artery is simply just an extension of the femoral artery. Now, elevation and pressure points are not necessarily the best way of handling it. Direct pressure is our primary goal. When we bandage, dressing goes on the wound, sterile dressing down on the wound, and then a bandage to hold it in place. And the bandage applies some pressure to make sure that there is pressure on that dressing to control the bleeding. Now, in this situation, we're showing a gauze bandage. And so in a gauze bandage, if you remember, we start out with a tail that's 12 to 18 inches long. We roll from the bottom towards the heart, and then we use that tail to tie off the bandage when we finally get finished. And we tie it off because now we can loosen that bandage and put more dressings on if we have to. The nice thing that we have on our backpacks now are the Coflex bandages. Now, these bandages are elastic bandages and they're self-adhering. So we don't need to start out with the tail. These are the kind of bandages that you've probably seen at the blood bank. If you give blood, they wrap you up with one of these after the blood loss, or blood gathering rather. Now, in this situation, we're putting pressure on this wound to control the bleeding, but we have to monitor that pressure because we don't want to make this into a tourniquet. And so once the bandage is in place, then we want to check a distal pulse. Now, that's a pulse away from the wound. So in this case, it would be a wrist pulse that you're checking to make sure that you have not restricted the blood loss. Now, if we cannot control the bleeding by the pressure dressing, our final thing is a tourniquet. Now, as we said before, the tourniquet is the initial thing that we use if we have an amputation or a partial amputation, even if it's not bleeding. But in other cases, a tourniquet is used only for arterial bleeding, the spurting type of bleeding that we talked about before. Now, the tourniquet goes between the wound and the heart. You don't put it below the wound, you put it between the wound and the heart, approximately 2 inches above that, never over a joint. And what you're trying to do is to save the joint if at all possible, because your indication here is we are going to sacrifice the limb to save the life. This is our last ditch effort to stop this bleeding or blood loss. And so in this situation, if there is a prosthesis in the future, we're better off if we save the joint for that prosthesis. Now, once it is in place, Then we close the windlass strap and record time and date on that, because if we can get this person to a medical center, there's a possibility of saving that limb in the 5 to 8 hour window that we have for that. Now, keep in mind, this is the last effort that we have to stop blood loss. Once it's in place, it's not removed and it's never covered. The other thing that we do after we record time and date on the windlass strap is we put a big T on their forehead so that everybody knows there's a tourniquet involved. As soon as professional responders are available, then it should be noted to them that someone has a tourniquet in place.
This is the CAT Gen 7 Combat Application Tourniquet. The CAT has been used by the U.S. military since 2005, and it has helped save countless lives. The CAT Gen 7 was developed to make field application easier than ever. I'm going to show you the proper way to apply the CAT to an arm wound. Let's say you have a wound right here. You want the CAT to sit 2 to 3 inches above the injury. For most people, that's about 3 finger widths. So you want the CAT to go about here. Ideally, the CAT should be applied directly to bare skin. You can apply the CAT temporarily over clothing, making sure there are no solid objects in the way. Loosen the CAT and then slide it over the injured arm. When it's in the right spot, pull the band tight. Then secure it back around itself, but not over the rod clips. The CAT is tight enough when you're unable to fit 3 fingers underneath it. If it's too loose, pull the band open, tighten it, refasten it, and recheck its tightness. Now twist the rod. Your goal is to get the CAT tight enough to stop the bleeding. Lock the rod into place and check for bleeding and a distal pulse. If there's still bleeding or a distal pulse, you can tighten the CAT with the rod, or even consider applying a second CAT right above the first. Once the bleeding has stopped and you can no longer feel a distal pulse, the CAT is properly tightened. Now you can route the band between the clips and over the rod. Secure the band with the time strap and record the time of application on the time strap. That's all there is to applying the CAT Gen 7. Quick, simple, and it could save your life.
Sorry.
Eventually you get the idea that we know what we're doing. But anyway, the third killer is shock. And this is the most difficult to diagnose in the field because it actually presents like an anxiety response. Someone is very nervous, they're upset by the disaster happening and all that sort of thing. And so what we really do is use the 3-2 can do technique for determining that the person is in shock. The first is their very rapid, shallow breathing, greater than 30 times a minute. If you can get close enough, the capillary refill is also a way to determine this. And capillary refill is simply pressing the palm of the hand and look to see how fast it recovers its color. The second thing is you can also pinch the thumbnail and to see how fast the color comes back to it. If it's greater than 2 seconds, it's an indication there's low blood flow in the extremities. And finally, the key thing, and this is probably the thing that you almost start out with, is to get the person to answer a question that you know the answer to. In other words, what's your name? You don't know what the name is. The key thing is to ask a simple question that you know the answer, or ask a sequence that requires them to do something. In other words, to squeeze my hand. Now, in this situation, we need to really calm this person down. We need to get that breathing under control. We also need to get the blood back to the main body cavity. And so we want them to sit down or lie down. Lie down is even better because now we can elevate the legs and support the knees. We're watching for any kind of airway obstruction here. And the other thing is we really need to keep them warm. So we have Mylar emergency blankets in our backpacks, and so that would be something that we rely on at this point to keep them warm. As I say, this is the most difficult thing to diagnose, but it also is going to think that accompanies excessive bleeding or airway loss and other types of emergency situations. Now, to summarize, in triage, our goal is to do the most good for the most people. We're going to treat the 3 killers and treat them where you find them, because we are so concerned about a spinal injury that we only transport if they are in immediate danger, for instance, a building collapse, fire, or something like that. After we do the original triage, we need to reassess our survivors often. And if you have questions, we do have Radio Central follow-up for medical advice, because we do have medical staff that we can check with to get advice on any kind of thing. The other thing is to use your volunteers. Have volunteers stay with people that you've gone through and sorted, and have them monitor people that are still in the site. Now, do we have questions? All right, then I shall turn it back over to Nigel.
Thank you, Pat.
I had a question, though, for the tourniquet, please.
Yes.
That's the last thing I ever want to have to do. But if I wasn't sure if I should apply the tourniquet or not, you just gave us the option that there may be a medical advisor that we could contact. That is news to me. So how exactly are we going to know if we have, for instance, a doctor or an EMT, sort of a person available that we can quickly check in with regarding such a drastic measure as a tourniquet?
The problem is that you're not going to have time to do that. And when you're actually applying a tourniquet, you're dealing with a 5-minute blood loss window. And so if you take that time to start calling someone and asking for advice, it's not going to work. So you have to make the determination in the field that I cannot control this bleeding by pressure, elevation, pressure points, additional dressings, additional dressings, additional dressings. And now I'm starting to think, okay, I've lost 1 liter of blood. I'm now into my 1.5 liters of blood. I have to make this determination myself and put that tourniquet in place.
Okay, thank you.
Mm-hmm.
Any other questions? Okay, thank you, Pat.
Mm-hmm.